Good morning, everyone, and welcome to the Tyro Multidisciplinary Seminars. It is indeed Friday, September 13th, but in spite of that, I anticipate that we will have a great deal of luck with this morning's program. Welcome all of you to this weekly format, and we do have quite the international panel to talk about a really important subset of what is normally perceived to be early stage papillary thyroid cancer. We are joined this morning by a group from Australia. Dr. Alex Papachristos is an endocrine surgeon at Royal North Shore Hospital in Sydney, and he is also senior lecturer at the University of Sydney. He is currently completing a PhD as well as having already completed a master's in surgical education. Dr. Kimchi Do is an endocrinology advanced trainee at, I hope I'm pronouncing this correctly, Nepean Hospital in Sydney, and a clinical associate lecturer at the University of Sydney. And finally, the senior member of this group is Dr. Matti, who's a staff specialist in endocrinology at Royal North Shore Hospital in Sydney and a senior lecturer in medicine at the University of Sydney. In addition to completing a research fellowship with Jim Fagan in New York at Memorial Sloan Kettering Cancer Center, she also completed a PhD focusing on RET-altered medullary and papillary thyroid cancers. She currently has a research lab at the Koling Institute of Medical Research in addition to her clinical activities. And I am thrilled to introduce our discussant this morning. Dr. Dana Hartl is chief of thyroid surgery of the thyroid surgery unit at Gustave Roussy Cancer Institute. She's a head and neck surgeon with particular expertise in advanced and reoperative thyroid cancer surgery. She has an extremely robust academic resume. She is a member, active member of multiple national and international societies, and we are really pleased and proud to have her as an active member of the Tyro Advisory Board. As a small advance plug here, Dr. Hartl, as many of you know, we have introduced a monthly podcast session and that's come out. Here it is on the second week of every month, and Dr. Hartl will be the host of that platform starting in 2025. And so today's discussion is a sneak preview of what you can expect for those podcasts. And so with that, I'm going to let the team from Sydney get started. Thank you all. And as always, I ask that our listeners send in your questions, and I will do my very best to get to them before the end of the hour here.
Good morning, everyone. Thank you for the introduction and for the opportunity to present this study, examining a unique subgroup of patients with papillary thyroid microcarcinoma who present with lateral lymphadenopathy. As you all know, there has been a rapid increase in the diagnosis of papillary thyroid microcarcinoma, mostly due to the increased availability and sensitivity of ultrasound. And with this, active surveillance management algorithms have evolved, and the long-term follow-up data demonstrates that this is a safe approach for appropriately selected patients. We also know that occult lymph node metastases are extremely common in papillary thyroid cancer and are usually not of clinical significance. However, there is a subgroup of patients with papillary thyroid microcarcinoma who present with clinically significant lymphadenopathy. And the literature suggests that in this situation, patients are at intermediate to high risk of disease recurrence. However, this population of patients has not been extensively studied, which really gave rise to the impetus for this project. So today I'll begin by discussing the relevant literature that informed the project design and hypothesis. And then I'll hand over to Dr. Kimchi Do, who will discuss the methods and results. And finally, Dr. Matti Gild to discuss the implications and clinical perspective. So when we examine the active surveillance data in papillary thyroid microcarcinoma, it demonstrates that prognosis is consistently excellent, with no patients developing distant mets at extended follow-up in these 9 studies. that collectively examined more than 5,000 patients, approximately half of which were from Japan, who were the pioneers of this approach. In addition, the development of new lymph node metastases during surveillance is rare, in the order of 1 to 3% at extended follow-up. Particularly when we look at the first two studies here that have reported 15 and 20-year data. So we know that the incidence of occult lymph node metastases is high. Central compartment involvement in up to 60% of patients, lateral compartment in up to 40%, which really highlights the fact that microscopic lymph node metastases in this group of patients are not clinically significant. So just moving on to the next slide, sorry, thank you. But what about the group of patients with PTC who have clinically involved nodes? When we look at the group of patients with clinical N1 disease, recurrence rates are in the order of 10 to 42%, with a median of 22%. However, in many of these studies, patients with papillary thyroid microcarcinomas are excluded or only make up a very small subset of the cohort. Having said that, in the risk stratification, the size of the primary tumor is less important. And so the question arises, does a 2-centimeter PTC with a 3-centimeter lateral nodal metastasis carry a similar prognosis to a 5-millimeter papillary thyroid microcarcinoma with the same 3-centimeter lateral nodal metastasis? So next slide, please. In this study of 259 papillary thyroid microcarcinoma patients, there was a subgroup analysis of 24 patients with clinically palpable involved nodes who underwent therapeutic lateral nodal dissection. And in this group, the local recurrence rate was 16.7% versus 0.4% for patients without palpable nodes. Also, the size of the primary tumor, whether it was less than 5 or more than 5 millimeters, did not predict recurrence. So this indicates that the group of patients with clinically involved nodes and papillary thyroid microcarcinoma have a very different disease biology, and we must be cautious about grouping them with the rest of the microcarcinoma cohort. In this Japanese cohort of 34 patients with clinically involved nodes and PTMC, again, local recurrence rate 21%, and 12% of patients developed distant metastases. And when patients were stratified according to the size of the largest node deposit, patients with lymph node size of greater than 3 centimeters had a 42% local recurrence rate, and a third developed distant metastases. In contrast, no patient with nodes less than 3 centimeters went on to develop distant mets. And so these two studies really informed the 2015 ATA guidelines and the risk stratification. But it's important to note that all of these patients were treated according to the Japanese guidelines and hence did not have radioactive iodine therapy following surgical treatment. So if we take a brief look at this table from the 2015 guidelines, when we look at risk stratification for disease recurrence in PTC, clinically apparent, sorry, that's not projecting very well, but the red box should encircle clinically apparent nodal disease at presentation, which confers a recurrence risk of approximately 20%. And when the lymph node is greater than 3 centimeters in size, the risk of disease recurrence is in the order of 30%. And the other point I'd like to highlight in this table is that the presence of a TERT mutation in PTC is noted to confer high risk of disease recurrence, although it's specifically not in the PTMC, or the papillary thyroid microcarcinoma patients. And so this gives rise to an interesting question in that, are there differences in the significance of genetic drivers when comparing PTC to papillary thyroid microcarcinomas? Are there differences in the genomic makeup of the microcarcinomas that are more aggressive and present with nodal disease compared to the indolent form that appears very stable and amenable to active surveillance? And so this study from MSK compared the genomic landscape of PTMCs in patients who presented with and without clinically important nodal metastases, comparing 40 pathological N1B patients with 71 pathological N0 patients. And interestingly, the genomic landscape did not differ between these two groups. However, the presence of mutational combinations such as BRAF and TP53 or BRAF and TERT were only present in the subset of 4 patients that presented with palpable lymph node metastases. And so this suggests that clinically significant lymphadenopathy may be associated with an accumulation of genetic mutations, analogous to the increased mutational burden that drives the progression of differentiated thyroid cancer to poorly differentiated or anaplastic thyroid cancer. But it also begs the question, what determines the degree to which the metastatic clones within a lymph node can increase their mutational burden? Or is this driven by seeding of additional clones that occurs with evolution of the primary tumor and the associated tumor heterogeneity? So when we compare this study to a Polish study that analyzed 430 patients with papillary thyroid microcarcinoma, they reported that 70% were BRAF driven, 12% had a TERT mutation, and 7% had both BRAF and TERT. But the authors concluded that there was no differential prognostic significance to having this mutational combination. However, the majority of this cohort, 91%, was either N0 or NX, and there were no clinically node-positive patients. So this is a different cohort of patients. This is much more representative of the indolent active surveillance papillary thyroid microcarcinoma patients. And it indicates that there must be additional components to the driver sequence required for patients to manifest an aggressive clinical phenotype. And just one last study to mention, this was an exploratory study looking at 20 N0 microcarcinoma patients and 24 clinical N1B patients. And they found that a number of genes were significantly upregulated compared in the N1B patients compared to the node-negative patients, which also corresponded to protein overexpression on the IHC analysis. This is very much an exploratory study, and the clinical significance of these results require further research. But this brings us back to our aim, which is to describe the outcomes of patients with papillary thyroid microcarcinoma who present with clinical N1B disease and have been treated according to the ATM management algorithm. And so I'll now hand over to Dr. Kimchi Do to describe the methods and results.
Sorry, it's just frozen. Sorry, thank you. So to do this, we performed a retrospective cohort study of patients treated at Royal North Shore Hospital over a 23-year period from 1997 to 2020. And Royal North Shore Hospital is the highest volume thyroid surgery unit in Australia. We looked at outcomes of patients with MicroPTCs presented with palpable lymphadenopathy. This is our MicroPTC CN1B group. And we compared this to 2 control groups. So the first control group were clinically detected MicroPTCs who didn't have lateral lymphadenopathy, which is our MicroPTC CN0 group. And we excluded MicroPTCs that were diagnosed incidentally after surgical treatment for another indication. Our other control group were larger PTCs where the primary tumor was greater than 10 millimeters, who also presented with palpable lateral lymphadenopathy, and this was our larger PTC CN1B group. We reviewed their baseline characteristics and their outcomes, including disease persistence and recurrence. And in this study, we defined recurrence as biochemical or structural disease following an undetectable thyroglobulin and negative ultrasound documented within 1 year of surgery. Biochemical recurrence was defined by a stimulated thyroglobulin greater than 10 nanograms per mil, and this also included patients who had new thyroglobulin antibody titers or rising thyroglobulin antibody titers. So over this 23-year period, there were more than 1,500 MicroPTCs diagnosed, of which 26 or 1.7% of them met the criteria for our study group here. There were 157 patients who met the criteria for our control group, and that was about 10% of the MicroPTCs diagnosed in this period. And during this period of time, 136 patients had larger PTC disease, which presented with lateral lymphadenopathy. As you can see here, most patients with CN1B disease, MicroPTC and larger PTC group were managed with total thyroidectomy, with the exception of one patient in the larger PTC group who had declined total thyroidectomy and therefore had a hemithyroidectomy. But all patients in the CN1B groups had adjuvant radioactive iodine following their surgeries. In contrast, patients with micro-PTCs who didn't have lateral lymphadenopathy, CN0 group, 85% of them had total thyroid, and only about half of these patients went on to have adjuvant radioactive iodine, which was decided on a case-by-case basis. And so these are our initial baseline characteristics, and I apologize for the table, but in the first column here, we can see our study group with the micro-PTCs with lateral lymphadenopathy. This is our control group 1, so micro-PTCs who didn't have lateral lymphadenopathy, and our larger PTC group here. And these p-value columns refer to the comparison between the control group and the study group. So in our study cohort, the mean age was 49 years, of which 65% of them female, and the ratio of involved lymph nodes out of the excised lymph nodes was 0.2. What I wanted to highlight here was that the size of the largest lateral lymph node deposit in our study group was 23 millimeters, and this didn't actually differ compared to the larger PTC CN1B group. Not surprisingly, the patients in our study group were more likely to have a higher ATA risk category compared to micro-PTCs who didn't have lateral lymphadenopathy. And the median follow-up time was 3.4 years compared to 1 to 1.5 years in the two different control groups. So following surgery, we had some, this is the data for their histology afterwards. So patients in our study group were more likely to have multifocality and extranodal extension compared to micro-PTCs who didn't have clinically apparent lateral lymphadenopathy. There was a trend towards increased vascular lymphovascular invasion, but this was not statistically significant. The larger PTC CN1B group were more likely to have lymphovascular invasion and extrathyroidal extension compared to our micro-PTC CN1B group. However, the rates of BRAF mutation positivity and the distribution of the histological subtype was similar between the control groups and the study group. So for patients who had radioactive iodine, we have data on what the stimulated post-operative thyroglobulin was following recombinant human thyrotropin or thyrogen. You can see that here in our micro-PTC CN0 group, as only about half of them had radioactive iodine, there was a fair amount of missing, 65% of them had missing data for what their post-op thyroglobulin was. So in our study group, 4 out of the 26 patients, or 15% of them, had a stimulated post-op thyroglobulin greater than 10 nanograms per mil, which suggests biochemical persistence. And of these 4 patients, 2 of them had evidence of structural disease. So one had a radioactive iodine-added lung metastases, and the other one had a morphologically abnormal level 2 lymph node, which was treated with percutaneous ethanol ablation. So that was 15% overall of the patients in the study group who had a post-op thyroglobulin greater than 10, in contrast to 2% in the micro-PTC group who didn't have lateral lymphadenopathy, but it did have similar rates of 18% in the larger PTC CN1B group. On the right, we have the table showing the proportion of patients that required multiple radioactive iodine doses and their mean cumulative dose. And overall in our study group with the micro-PTCs with lateral lymphadenopathy, they were more likely to require multiple radioactive iodine compared to micro-PTC CN0 patients, but less so than their larger PTC counterparts. So of these 85% of patients in our study group who had an excellent response to initial therapy, one patient did require reoperative surgery thereafter. And this was due to structural recurrence at a level 2 lymph node after 2 years from their initial surgery. In this study, we distinguished between structural persistence and recurrence by whether disease was found less than or more than 12 months after eventual surgery. However, given this was at a level 2B lymph node, it may have been that this was not completely cleared at initial surgery. And reassuringly, since this patient has had redo lymph node dissection, they now have an undetectable thyroglobulin. But overall, I want to stress that in our study group, it was just one patient who needed reoperative surgery compared to 26% of patients in the larger PTC CN1B group. And the rates of reoperative surgery were quite similar between these two MicroPTC groups. So this was our survival analyses, and in this part, we only included patients who didn't have any evidence of structural disease within 1 year of surgery. And I should also note that during this whole study period, none of our patients died. So in green, we see our study group, the MicroPTC CN1B disease, and it's quite similar to the red line here, which is our control group 1, that is MicroPTCs who didn't have palpable lateral lymphadenopathy. But overall, we can see that the risk of structural recurrence was much worse in the larger PTC group who did have lateral lymphadenopathy. And on our table here, we have the mean structural disease-free survival was much less in the larger PTC group compared to the MicroPTC who had lateral lymphadenopathy, and 59% of the larger PTC group achieved 5-year disease-free survival in comparison to 94% in our MicroPTC CN1B group and 82% in the MicroPTCs who didn't have lateral lymphadenopathy. So this was our disease status at last follow-up between all the groups. So now our group of interest is in the middle here. So 85% of our MicroPTC CN1B patients were disease-free at last follow-up, where the remaining 15% have a biochemically or structurally incomplete response. This is in contrast to the larger PTC group, where only 68% of them were disease-free at last follow-up, but 98% of the MicroPTCs who didn't have lateral lymphadenopathy were disease-free at last follow-up. So what our data seems to suggest is that patients with MicroPTCs and who present with lateral lymphadenopathy have better clinical outcomes compared to their larger PTC counterparts, but worse outcomes than patients with MicroPTCs who don't have lateral lymphadenopathy. Of our MicroPTC CN1B patients who had an excellent response to initial therapy, 95% of them were disease-free at last follow-up. And so the response to initial therapy can be helpful to predict long-term disease-free survival and be useful for their prognostication. Interestingly, in our study, the size of the lymph node deposit did not appear to correlate to the initial response to therapy, nor did it correlate to the risk of disease persistence or recurrence. And so for the final part of this talk, I'll hand over to Dr. Gild.
Thank you so much, Kim, and thank you for presenting our study so beautifully, and Alex for you presenting that literature. So I'm just going to make a couple of comments as the endocrinologist and maybe just in the context of some of the changing themes in thyroid cancer research over the last sort of 20 years. So the first thing I wanted to just mention was this, this drawing out this focus on lymph node metastases and the dichotomy of the importance of lymph nodes in prognosis of our patients. And I think it's very obvious that for most of our patients, they will have good outcomes, and particularly the MicroPTC cohort. But then we do have this dichotomy, and we know that 50 to 60% of our patients will have lymph node metastases. And, you know, in nearly every mortality risk staging system, we've got lymph node mets are considered an important risk variable. And sometimes when we have this situation, we have PTC overtreatment occurring when lymph node metastases are present, which inevitably increases the risk of treatment-associated complications. And so what I wanted to highlight in this discussion part is really the crucial difference in these identifying clinically apparent nodes, that these are different and these have an apparent different biology to the microscopically involved nodes, those that are incidentally picked up when you're doing your central node dissection. And this is important in ongoing risk stratification and is known to increase recurrence risk when it's clinically apparent. Can you move on to the next slide? Thanks. So one thing I wanted to mention is, as I said before, the changes in clinical practice over time and how our data needs to be interpreted in the new context of how we're practicing medicine now, which is different, certainly in terms of surgery and in terms of radioactive iodine, even 25 years ago when we started collecting this data, and even 10 years ago when we started getting this data from the studies that suggest that we can use lower doses of radioactive iodine. So what we've shown here in our data is with the standard ATA algorithm treatment, the recurrence of the cohort of the clinically palpable lateral lymph node disease, patients with MicroPTC, is low, and only really one of our patients had that reoperation. And it is also relevant to compare this to the Japanese data, which showed in a similar cohort. So as Alex described in their patients, they had 24 patients who had a therapeutic lymph node dissection with a 16% recurrence risk. And in our cohort, the numbers are much lower. And the main difference that we can identify is that our patient received radioactive iodine. Now, we do have the mean cumulative dose radioactive iodine for our patients, but we don't have the individual one. And this is relevant because of, as I said, the changes in what we're actually giving patients in terms of dose activity has significantly reduced. And we have, we have in our clinical lymph node cohort, all the patients received a total thyroidectomy and radioactive iodine. And in the MicroPTC without any lymph node control cohort, 85% of these patients had a total thyroidectomy and almost half received radioactive iodine. And as I mentioned, clearly this is retrospective and goes back 25 years. And so this current practice is going to be very different today. I mean, from 2015, we've had the option to really give these patients lobectomies and no radioactive iodine, or even, if need be, a total thyroidectomy with no or even low dose radioactive iodine. And so that control group, the comparison of that is going to be quite different moving forward, because we're not going to be practicing in a similar way. And we know that this is actually happening, and we've got evidence, all around the world. I've just reported one study showing the prescription radioactive iodine has reduced in the early part of the 21st century. And in our group, Dr. Ayanthi Wijawardena looked at our cohort in 2021 and found that the evolution of radioiodine activities is consistent with the translation of ATA guidelines in clinical practice. And she found that these lower activities were not associated with an increase in recurrence in the low-risk thyroid cancer patients. So perhaps there wouldn't be a difference in the control cohort if we are seeing similar numbers and similar pictures. So what I guess we wanted to say is that in that clinical lateral lymph node cohort, they are still at a moderate risk of recurrence. So I think it's very likely that we're still going to recommend completion thyroidectomy and radioactive iodine with these patients to reduce the recurrence risk because of that 20% structural recurrence risk. Okay, next slide. Okay, yeah, thank you. And so I guess the other things I just wanted to talk about in the discussion was that it's as Alex introduced us, there's worthwhile to consider any molecular clues in the difference in the biologic behavior in our cohort of interest. And we can examine these established poor prognosticators like the TERT promoter mutation and the BRAF mutation, which when we're looking at the recurrence rates. And in the MicroPTCs in that Polish studies, we looked at the prevalence of the TERT promoter and BRAF concomitant mutations in MicroPTCs, and all of these patients did well. And reporting the existence of these combined mutations is usually associated, of course, with worse disease-specific survival. But in these MicroPTCs, it wasn't, because, as we said, most of them are doing well regardless. But what's really important to make note of here is that these were indolent MicroPTCs as opposed to our cohort, which were clinically detected MicroPTCs. And these people had worse outcomes for our patients. And, perhaps then we need to think about what's going on in the biological setting with these cumulative mutations in the lymph nodes in that MSK paper. And we need to really map these patients and understand how this is affecting their prognosis. So what I wanted to take from here is that not all MicroPTCs are the same. And as we start to implement active surveillance as standard practice for low-risk PTC, sometimes people do interchangeably use MicroPTC as with low-risk PTC. And for the most part, that's probably fair and probably true. But it is important to recognize that this cohort is different and is behaving differently, and that when they're clinically detected, not incidentally detected. And that's not to say that people, of course, shouldn't employ active surveillance, but then we need to use those keywords like if they're appropriate and ideal for the tumor and for the patient. But we would argue that these tumors are not ideal because of they are behaving biologically differently. And the other thing that I wanted to make the point of for the trainees on the call is that this is really the importance of clinical examination. You know, the patient sitting in front of us, you know, often we can just rely on the ultrasound, but we actually need to examine the patient as well, because they need to be properly examined for lateral nodes, because we show that this impacts on prognosis. And I suppose nowadays with ultrasound becoming so sensitive, our radiology colleagues are very helpful in identifying these lateral nodes. So perhaps when we look at this group going forward, it is a more heterogeneous group, because the lateral nodes will be identified both through ultrasound and clinically on examination. But in our study, we can show the importance of clinical examination affecting the outcome. So on that note, I'll just say thank you to Dr. Erkin for inviting us to present this paper and discuss the literature, and really keen to hear Dr. Hartl's thoughts on her perspective. Thank you.
Particularly want to congratulate all three of you on a very clear, very, very interesting presentation. And I particularly want to call to your attention that this is a group that over years has a history of publishing, of asking the right questions and getting the data and publishing. And so really congratulations on your whole team and on the history and continuing the tradition from your group. And I don't think, for trainees out there too, your comment on clinical examination is very important. And I think I want to also maybe just call to the attention of our listeners that this takes a lot of work. Collecting this data, teasing out the numbers, analyzing it, writing the paper, and getting it published, going through the peer review and getting it published in a prestigious journal. That just takes a lot of work. So I just want to say bravo, congratulations, and keep up the good work. So on that, I just have a few comments. I have maybe 15 minutes. My disclosures for Medtronic. And so you already saw this. This is just citing the paper. The question is there a difference between microcarcinoma without lymph node metastases, microcarcinoma with lymph node metastases? And then there's this other comparison where they were looking at microcarcinoma with lymph nodes versus macrocarcinoma with lymph nodes. So there's kind of there's these two comparisons going on in parallel. And I just want to start with the first comparison with the palpable lymph node N1B microcarcinoma versus the N0. And as you already saw, I think some of this is the paper that Alex, I'm going to just go over these really quickly because you did a very nice job of reviewing the literature. But this is from our Japanese colleagues, Dr. Sugitani in Tokyo, who for microcarcinoma showed that lymph node metastases were related to cause-specific survival. And again, that the size of the lymph node is a prognostic factor. So this led to the ATA recommendations. And again, you already saw this table where we have, as you see in the American Thyroid Association, risk stratification tables, the number of metastatic nodes. These are where those are micrometastatic. And then when you get to clinical, all detected on ultrasound, and then the nodal extension. So there's kind of a continuum here, going from more micro, then to clinical disease. So I'm going to skip this one, you already saw it. So I think everybody's convinced that nodal metastases is a prognostic factor. And so what the data in this showed, you already saw this, and that patients who have papillary microcarcinoma with N1 disease had a lower rate of, let me get rid of this here, a lower rate of excellent response at last follow-up. But I do want to draw your attention that, MicroPTC, the MicroPTC group with the CNB, they did have a longer follow-up. So that is something to keep in mind, that there's maybe the difference is maybe not as large. Maybe if we followed these patients a bit longer, they would have had a little bit more recurrence. Or if we followed these patients a little bit longer, maybe or a little bit less, maybe we'd be right here and we'd have more excellent response. So keep in mind that there are some differences in these groups, and there maybe the numbers do have to be interpreted in that light. Again, just repeating what was said, is a very good prognosis in these patients, of course, and there was, as you saw there earlier, there was very few reoperative surgeries in both groups because the initial surgery there was complete. Looking at and you already saw some of this reflection, and you saw the review of the literature that Alex presented earlier on, that as we see the results from active surveillance, particularly in young people, actually, there is a certain number of patients who are going to show lymph node metastases. They're going to show up. These are ultrasound probably detected lymph nodes, not necessarily palpable as compared to others. So there is something going on here that's in the younger patients in micropapillary carcinoma that does sort of raise a question that this is maybe a specific entity. And at 10 years, this is Dr. Miyoshi's present publication that patients less than 40 at 10 years, nodal metastases were detected in 16% of patients. So for me, 16% is starting to get maybe clinically significant. And so I think that one of the questions is this just, if we wait long enough, are these patients all going to show lymph node metastases on ultrasound? But maybe not. And I think that's what was very interesting and important about this publication, is to show that this is most probably a particular specific entity, the microcarcinoma, that develops lymph node metastases. There was in this group, this is the table 1 from Papachristos and their group's presentation. There were no differences in terms of the, there was a little bit more microfractality and extranodal extension, but otherwise there was, in terms of other risk factors, in terms of the initial tumor, in terms of the primary tumor, there was no difference in lymphovascular invasion, extrathyroid extension, or in histology. There were no aggressive or very few aggressive histological subtypes. And then no difference in BRAF, although there was a lot of missing data. And so, and you already saw this slide, great minds, Alex. I think that it's really interesting, and the discussion in the paper is fabulous. So I invite you to read it, that there are differences, genomic differences in patients that have lymph node metastases and microcarcinoma versus patients with no lymph nodes. And BRAF is maybe there, but it doesn't seem to be answering the whole question. TERT and TP53 are, of course, associated with worse prognosis in most thyroid cancers, and in microcarcinoma in particular, and associated with larger nodes. But then this is, I really like this paper too, is that they looked at really whole genome analysis, and they saw that there's a lot more going on here when you look at microcarcinoma with and without lymph node metastases. And so you've got some upregulation and some downregulation. And they actually tackled this with a machine learning to try to sort out which patients have lymph node metastases, which patients have the genomic profile for lymph node metastases and which don't. And then when they applied it to a population with about 10% microcarcinoma having lateral lymph node metastases, which is similar to the 15% that was in your population, they end up with they find a negative predictive value that is ruling out patients that are susceptible to have lymph node metastases that's very high, that's 98%. So you can have a rule out test. And I think it's really interesting to maybe try to apply this prospectively for active surveillance and to see really which patients are going to evolve, and can we predict that, and maybe that there are patients that in these categories that should not be subjected, or at least informed that they are at higher risk of having lymph node metastases if they're under active surveillance. And again, another analysis of microcarcinoma with and without lymph node metastases in there. It's not just BRAF; they're finding other abnormalities in these groups. So I think what we know now is just the emerged part of the iceberg, and I'm really excited to see in the next few years. I'm sure we're going to have a lot more information about the molecular analysis in microcarcinoma to be able to tease out which patients are more likely to have lymph node metastases and involve in the neck. So definitely this is a very important information that this paper has brought about, that clinical lymph nodes are important regardless of even though it's microcarcinoma. So the second part of this was the comparison with microcarcinoma with palpable lateral lymph node metastases and macrocarcinoma that is more than 1 centimeter. And the question was, should size be in that? Going back one, you see all these different risk factors. You don't see tumor size in here really, except for microcarcinoma. So once it gets to be macro, and the question is, shouldn't tumor size be in here somewhere? And so the question is, outcomes are different, and they say that comparing different outcomes, the size of the primary tumor is more important than just the lymph node metastases. And this is from the paper, you saw this already, that there's a difference in structural disease-free survival, fewer patients with an excellent response at last follow-up in the larger PTC group. But then again, there was also a longer follow-up in this larger PTC group. So these numbers need to be interpreted in light of that. But, this is a really bad joke, and I apologize, but N1B or not to be, that is the question. And I think this is very interesting if we look at the details of the data set in this publication, really asking the question. And this is a cut and paste from the publication in Thyroid, that actually, if you look at the we're looking at the MicroPTC CN1B and the larger control group, there are actually more lymph nodes on average, more metastatic nodes in the larger PTC group. There were more nodes excised on average. So the question is, were more neck levels dissected? Was there more extensive neck dissection? Was there more extensive neck disease? And then in the actual paper publication that came out, the size was slightly different. So they were a little bit bigger in this group. And we already saw this slide. It was, great presentation by Dr. Do. And I'd like to call your attention to this group also, that patients, 10 patients out of the group, so maybe about a third of those who had reoperative surgery, had structurally persistent disease, which means that probably the initial surgery was incomplete, initial workup was maybe incomplete, or maybe we're talking about disease that's actually quite extensive, and it's very difficult in a lot of these cases to actually remove everything on the first surgery. Sometimes we're talking about hidden lymph nodes, kind of in areas that we don't address generally, or in neck levels that weren't explored correctly initially. So and we know that is a risk factor then even for further recurrence. There are other prognostic factors that I found seem to be different in this group, the micro-PTC and the larger PTC, that when you look at the T stage, was different. Of course, the size of the tumor is different, but there's also other elements in terms of the initial tumor. There were more T1B with macroscopic extrathyroidal extension, more T4A as well, recurrent nerve, trachea, esophagus, or larynx. There was also more lymphovascular invasion and more extrathyroidal extension. The extranodal extension was not different, although 43 and 23 maybe just is a lack of statistical power. Anyway, in terms of primary tumor, there was a statistical difference. And then when we look at histology, there were a subset of patients in the larger PTC that had aggressive variants. And we know that these aggressive variants do have a higher rate of recurrence as compared to other papillary thyroid carcinoma, in particular the diffuse sclerosis variant. As you know, it's known that there's more extensive lymph node invasion, higher incidence of extrathyroidal extension, local invasion, different biologically, and it's known to have higher rates of structurally recurrent disease. So this group of patients with the MicroPTC versus the macro PTC, they were similar, of course, in terms of lymph nodes, but I think the group with the MicroPTC had other prognostic factors in terms of more lymph nodes, maybe more extensive lymph node involvement, more extrathyroidal extension, more vascular invasion. So this puts this group has additional risk factors for recurrence. And this again comes from the American Thyroid Association guidelines. Lymph nodes put patients at high risk, palpable lymph nodes more than 3 centimeters put patients at high risk. But then again, all these other primary tumor characteristics come into play. So the question is, are these the same tumors, just with less extensive tumor involvement? But I think maybe we had, as I showed, there were some higher risk patients in larger PTC group with more aggressive tumor subtypes. So are we really talking about true biological differences in terms of a bigger tumor and a smaller tumor, or are there some other prognostic factors in here? And I think we got to keep in mind that there are bad lymph nodes, but there are also bad tumors with lymph nodes, the sclerosing, the extrathyroidal extension in particular. So does tumor size really matter? I think maybe it would be interesting to have maybe gotten rid of some of that aggressive pathology and the patients who had gross extrathyroidal extension to maybe compare that and see if the prognosis is really that comparable. Anyway, so the idea is just to say that we need to really be careful in retrospective studies to be able to, when we're making conclusions about outcomes, to have comparable groups, to not have confounding factors and biases to improve our level of evidence. So in conclusion, the MicroPTC, I think that's a very important take-home message, is that these are probably different diseases. They remain an excellent prognosis. And I'm very excited to see that molecular analysis is probably going to give us a little more information about how microcarcinoma evolves in each patient, individual patients, to be able to inform patients more precisely on how their tumor is going to behave for active surveillance. And then compared to larger tumors, I think we really have to be careful, because larger tumors have other risk factors involved as well, and oftentimes. So we have to, it's not always easy how to tease out the bad lymph nodes from the bad tumors. So thank you so much for your attention. Thank our group from USWC. I want to thank the Thank Foundation and Tyro and Mark Erkin for the invitation and for your attention.
Great. That was really terrific. Great presentation of this paper, great discussion. Maybe I'll give Matti, Alex, Kimchi an opportunity to comment on Dr. Hartl's important comments here. And then I have just a few questions of my own.
Yeah, I can start. And thank you, Dr. Hartl, for such a nuanced, thorough review of our paper. You've given me so many ideas now. So thank you. Number one, I totally think we should go back and exclude the diffuse sclerosing. I think absolutely it's a completely different disease. The rearrangements are going to be, you know, we know that that's a different disease. So I think that was really, really thank you for highlighting that. The other thing I wanted to say is just make two comments about can we predict for N1B disease when we've got our active surveillance patients? And I suppose you're right. I mean, it's so exciting to think about what we're going to find out from all these molecular signatures, but practically, certainly in Australia, I mean, the idea that we would be able to do genomic analysis before we did active surveillance in these low-risk patients, no one's going to be paying for that here. And, you know, I think we have a difficult time in Australia even getting molecular analysis of indeterminate thyroid nodules because we have to pay, you know, we have a different health system. So, you know, our patients would have to pay $2,000 for ThyroSeq to send it to the US. So it's quite different. I think it's important to think about cost and accessibility because, and I guess, yeah, that's something that we struggle with quite a lot. But yeah, it'd be fantastic to be able to do that. And the last comment I wanted to make was I think when you said, you know, is BRAF is not answering the whole question, I think that's like the clincher of, you know, molecular analysis in thyroid cancer over the last 20 years, right? I mean, we hung on to this oncogene and it is so important and we're learning so much about it. But there's been so much debate in the literature about BRAF in PTC and whether it's a negative prognosticator, whether it actually is associated with recurrence, with increased mortality. You know, there's some studies that say yes, some studies that say no. And what's really become apparent is it's the coexistence of multiple mutations, either with TERT promoter mutations or through the PI3 kinase AKT pathway, that is really driving the poorer prognosis. And if that's the case in the general PTC population, then yes, it's probably the case, you know, in the MicroPTC population as well, which is what you were referring to. So yeah, those were my comments, and thank you again. I don't know if Alex, you had any from a surgical perspective?
First of all, on the comment about the disease persistence and recurrence and the distinction between the two, you know, I definitely agree that it's very difficult to adjust for all these confounders in a retrospective study, and certainly from a surgical point of view, you sort of have to wonder or presume that these patients had, you know, detectable disease at the index operation that, for whatever reason, hadn't been cleared. And the other thing I wanted to mention was I liked your slide with the iceberg metaphor, and I think when I was looking through those studies that were sort of the exploratory genomic analyses of comparing the two groups, what really struck me was the vast number of you know, potential genes that are being looked at and screened that, you know, are so far from our clinical practice. But, you know, maybe as with machine learning, with AI, maybe that can be sort of something that's from a data point of view more accessible. So yeah, I certainly think that there's a long way to go in terms of understanding the tumor biology and predicting, you know, which patients are going to behave in an indolent way and which are more aggressive. So, but yeah, no, I completely agree with all the comments about the sort of retrospective nature and the limitations that are associated with that.
Great. Thank you. So I have a fundamental question about the term clinically evident, clinically apparent. You comment on this in the introduction to the paper, that clinically evident can be a range of distinctions from an ultrasound evident to palpable to evident disease that's found at the time of surgery when the surgeon opens up the central compartment. I find that in my own thoughts about this, that palpable disease may not be a standard that is as reliable, because you've got body habitus, you've got differences with respect to what a person's finger sensitivity is, I wonder why you chose that versus ultrasound as being the standard of for clinically evident.
I think first of all, it's a very important point, and especially as our assessment of these patients has changed over the years, and ultrasound becomes routine, that the sensitivity of detecting the lymph nodes preoperatively will change inevitably with time, and so perhaps these days the patients who we're identifying what would be called clinical N1 disease, so ultrasound detected, biopsied, and then treated with a lateral node dissection, there will be a group of patients there that 15 years ago wouldn't have fallen into that category. I think initially the reason why we chose that definition was to try to compare it to these seminal studies from the Japanese data set, which mentioned the palpable lymphadenopathy. But certainly then also, with patients who have different body habitus, and, if you compare a slim Japanese patient's neck to a, morbidly obese Australian neck, that again, there's going to be inherent differences there. So I think that was, there are many layers to that, but I think it was just more a practical decision more than anything to try to compare it to those original studies, and to try and capture the patients who really are presenting with a bulky lateral nodes, rather than the 1 centimeter slightly abnormal morphology on ultrasound that gets an FNA and is found to be involved. So I'm not sure whether that completely answers the question, but it's a very difficult area to study, given the degree to which it's changed over time, I think.
Yeah. So
Can I also comment quickly?
Yep.
That this paper came about from our multidisciplinary meetings with our colleagues, and when we would, like, I don't know, maybe 6 or 7 years ago, and every time someone would present one of these kind of cases, the more senior colleagues would sort of like, cringe their eyes up and go, oh, there's something funny about these people, we've got to be careful about them. And then we went back to the database and said, hang on, we need to actually look at this, systematically, and look at these patients, because there's just, there was this like gut feeling, that these research papers come out of, and then people would say, oh no, you've got to do totals and radioactive iodine, there's something about them. And, then all this molecular data came out, and and our paper, and I think that it's really helpful because it does help us prognosticate for these patients.
Sure. Do you have any idea what the number of patients in your database who met clinic who were had ultrasound evident lateral compartment nodes that were not palpable and were excluded from this study? Is there any way to wrap your head around that one, or because that would, I just wonder if that group would have changed the way this was analyzed here. Let me ask Dr. Hartl, what in your hands do you consider, what's your standard for clinically evident disease?
Yeah, I think there is neck palpation, and I just can't encourage colleagues to really get their hands on patients, because sometimes you have surprises that, the ultrasound size kind of, sometimes they're like very relaxed about stuff, and then you actually palpate a really hard nodule or really, something. So clinical evaluation is really very important. But I would think it's what you said earlier, Mark, is seeing it on ultrasound, a suspicious node, having FNA on it, having thyroglobulin in the washout fluid. For me, that's clinical, because it means we know it's there and we're going to remove it. So as compared to occult metastases, where we find them incidentally when we do a prophylactic neck dissection, or you find them incidentally on your lobectomy specimen or your thyroid specimen. So I think it's the ones that we know they're metastatic in the neck before we go in.
So the central compartment is certainly a little bit less reliable from clinical exam and ultrasound. So should we exclude those patients who you open up the neck and there's a cystic lymph node or a blue lymph node, or one that you can feel readily when you palpate that node intraoperatively? Is that not clinically evident? Obviously, it depends on your definition here, but certainly it's not occult and it's not, I guess, incidental in terms of how you might look at that.
No, absolutely, you're right. When you look at it and when you open up and you see it, then again, that's not in my experience. But I'm really lucky to have some really experienced ultrasound physicians that you and sometimes these are so small that you really, I mean, in my opinion, in my experience, that doesn't happen that often. That you go in there and you've had the surprise. But yes, you're absolutely right. If you see it, and I would say also though, if you see that, you're going to want to get frozen section on it, because sometimes we have suspicious nodes and we think they're suspicious and all it is thyroiditis. So I'm not sure if it's one of those black cystic nodes. I agree, but suspicious nodes in the could be thyroiditis. So I think the surgeon's eye and the surgeon's finger is not very sensitive or specific.
Great. We are up against the 9 o'clock hour here in New York. I have no idea what it is in Sydney. I shudder to think what that number is, or what the time is. But I do want to thank everybody for who's on the panel for your contributions. I also reiterate Dr. Hartl's comment about what a monumental effort it is to have pulled this data together, and thank you for the insights of that. So with that, I invite you all to come back next week. We are going to be running a tumor board with Mike Tuttle as our moderator, and cases being presented from Seattle with Dr. Maura Roth. So thanks, everybody. Stay well and take care now.
Thanks. Good job, you guys.
Thank you so much. That was great. Thank you for having us.
Thanks.